When an Ebola outbreak swept across West Africa in 2013, claiming thousands of lives in Liberia, Sierra Leone and Guinea, the international community was gripped by hysteria. Experts grimly predicted that millions would be infected within months, yet by the middle of 2014, the disease was already going into decline in Africa itself. So why did outside observers get it so wrong? In this episode of the IDS Between the Lines podcast, Catherine Grant from the IDS-led Pandemic Preparedness project talks to Paul Richards, an anthropologist with over 45 years' experience of living and working in West Africa, and author of the book Ebola, How a People's Science Helped End an Epidemic. In the podcast, and drawing on extensive first-hand experiences in Sierra Leone, Paul and Catherine discussed that the international community's panicky response failed to take account of local expertise and common sense. Crucially, they discussed that the humanitarian response to the disease was most effective in those areas where it supported these initiatives. This podcast asks what lessons can we learn from using local knowledge in countries like Sierra Leone to combat past epidemics like the Ebola outbreak and the recent COVID-19 pandemic, and how these lessons can teach us to cope better with future pandemics by using local knowledge along with other national and international health systems.
Hello, I'd like to welcome Professor Paul Richards, who is an Emeritus Professor of Technology and Agrarian Development at Wageningen University in the Netherlands, and an Adjunct Professor at Najala University in Central Sierra Leone. Thank you very much for taking the time to come and speak to us today.
Thank you.
He's here to talk to us about his book today, which is Ebola, How a People's Science Helped End an Epidemic, and how the learnings from this can and were applied during COVID-19 and beyond. I was wondering if you could provide a brief overview of your book.
Ebola epidemic. There'd been outbreaks, but they were contained in rural areas of Central Africa mainly. And this was the first time we'd actually had a full-scale country to country. And so 3 countries were affected in West Africa, but Sierra Leone was perhaps the worst affected. And I was there at the time. And so the first part of the book is basically a factual account of how the disease spread to West Africa and what the consequences were. The second half, the middle third rather, deals with a big problem between local people and the international Ebola responders. The international Ebola responders became convinced that there was a connection between burial, funerals, and the spread of the disease. What they noticed was that there was a strong correlation, that all the people that developed Ebola in their recent history, they'd attended a funeral of someone that had been buried with Ebola. But it's one of those kind of nonsense correlations, because in fact, it's not really attending the funeral that causes you to catch Ebola. It's the fact that you've gone to a funeral because you've been closely associated with someone who's died of Ebola, and you've helped try and comfort the patient in their dying hours, or you've taken part in preparing the body for the funeral. It's not the funeral itself. It's the process of nursing the patient in the last stages of the disease, and then in the most immediate aftermath of the disease before you reach the funeral. But the banning of funerals created an uproar in Sierra Leone, because people regard funerals as really significant events, and because society can't work. It's one of the poorest countries in the world, and mainly your assets don't lie in property or bank accounts or anything. They lie in people. In fact, some anthropologists have used the useful phrase wealth in people. So when people's wealth is in people, they pay close attention to their arrival, their significant life events, and then their final departure. If you don't do that, then people fear, quite rightly, that society will fall apart. The basis for social cooperation is gone. So this was really an existential threat as far as people were concerned when the international responders said that funerals must be banned. So that became something that I looked at very closely in the field. We started to collect a lot of material on whether it was true and what the pattern was of people's involvement with Ebola cases and so on and so forth. And that was when I realized, of course, it was a false correlation. But the real issue was, how do you protect people when they're nursing a patient in the last stages of the disease, or when they're then necessarily preparing the body for an eventual funeral. And that led to a big debate in the international community among the responders. And some of them took the line that, no, it's far too dangerous. We can't take any chances. We don't care what cultural significance funerals have. We're going to ban the lot. But then they found that that was counterproductive. And people started to carry out burials, so-called in secret. So the epidemic was getting worse rather than better. But then the third part of the book describes how, in fact, in some areas, the disease was already turning down, even as the international responders were arriving. So that was where we focused our attention in terms of the actual research. We wanted to know why it was that these communities who hadn't yet had the benefit of international support to end the disease, how they had managed to cope with the disease. And then we found a very different story. We found that people had worked out how the infection worked, and then they decided how they were going to protect themselves. And so they'd introduced their own quarantine measures, they'd introduced their own so-called safe burial measures to protect themselves. They improvised protection. They didn't have international resources, they didn't have supplies of PPE. In some cases, they were able to get chlorine, but that was basically all they were able to get. Some chlorine that they could douse down places where bodies had been handled and so on. But by and large, they were improvising with whatever lay to hand, and they made a great deal of use of black plastic bags and making mittens to handle patients and tie the bags to their hands, that kind of thing. And it worked. And basically, the disease was disappearing. In fact, the international community had to create a new terminology. They referred to the districts in which Ebola had been present, but now no longer was spreading, as silent districts. And the trouble was they never asked what caused this silence. So this is what the third part of the book is dealing with. And I needed a name for that because it's not exactly traditional knowledge, because Ebola had never been experienced in West Africa. It was a new thing. So people had learned for themselves what it was that was causing infection and how they could control it. So I like the term people science that someone suggested to me. And that was what I used in the subtitle of the book, is how a people science helped end an epidemic.
Thank you very much for that great summary, and it's really interesting to hear how people adapted and came up with their own solutions before the international community could fully intervene. Was there any particular personal experiences or stories from individuals or communities that you encountered during your research that particularly resonated with you, or that you'd like to share?
But one in particular was that I became friends with the paramount chief in Jawe chiefdom in Kailaon district, Chief Kalon. And his chiefdom had been very badly affected, and he personally had been very badly affected because his wife, I think, was the second or the third case of Ebola in Sierra Leone. And his daughter then subsequently died because she'd nursed her mother through the sickness. And Chief Kalon was locked in his house because by then the international advice, or the government advice, was you have to spend, I think it's 40 days in quarantine. Anyhow, he had to do a double quarantine because his wife died and then his daughter died 3 or 4 weeks later. And all the while, his chiefdom was being devastated by the spread of Ebola. So he said, rather than do nothing and lie on his bed worrying about whether he was going to die of Ebola, he opened the windows and called the youth of the chiefdom together, and he got his youth leaders mobilized, and they volunteered to save the chiefdom. And they did it with great aplomb, really. I mean, they saw themselves as fighting a battle, and they made use of the language they'd used in the war about citizen civil defense and so on. And they were remobilizing to fight this new enemy that was trying to destroy them. And they went everywhere, tracing cases. Chief Kalon had a burial team. All he could do was basically try and get some basic facilities for them. So he managed to get some chlorine sent up. And then he explained to them, because he himself had some medical training. I think he'd been a dispenser or he'd been a village nurse or something. So he knew how infection worked and what you needed to do basically to protect yourself from infection. So he was instructing his people through the window of his bedroom, and they were then translating that into whatever they could do to improvise effective ways. And he introduced me latterly to the young man who'd led his burial team. They just had a hand cart, and they went everywhere picking up bodies and burying them as safely as they could using improvised protection and so on and so forth. And he said he'd seen that young man actually pick up bodies with his bare hands because he had no protection. But somehow he'd never become infected. So a question was then raised, in fact, which is still unresolved, as to the extent to which people who are close to the disease develop some natural immunities. And there is some scientific evidence now that there are people who've been close to Ebola cases who've never had Ebola, but have developed an immune reaction to the disease. So there is some evidence that the downturn was not just through correct procedure, but it was also that people were becoming somehow immunized to the disease. And that was a very enlightening experience to talk to Chief Calon and to his people about how they'd actually managed to turn the epidemic down. And indeed, he got some publicity. He was in the national newspapers, and he and his fellow chiefs, they all communicated by cell phone, telephone, and they worked out a set of bylaws, because paramount chiefs or chiefs in council are allowed to pass bylaws for their chiefdoms. So they'd all adopted bylaws on Ebola control. And eventually the government realized this was the way to deal with the problem nationally, as well as just in Kailan district. So in August 2014, the National Parliament adopted the bylaws that had been developed in Kailan district by the local chiefs. And a lot of the downturn in the epidemic took place. Not everyone agreed with the bylaws, and they were breaking them all over the place. But they often quickly saw that if they didn't follow the rules, then they got hit by the disease. So there are a number of chiefdoms where strong paramount chiefs insisted on blocking people coming into the chiefdom. Even your own relatives were not allowed to spend a night in your village if they came on a visit and so forth. And those chiefs then found that they got no infection at all, even when they were surrounded by chiefdoms that had outbreaks and quite large numbers of cases. So then it became a kind of national competition to show that you kept your chiefdom free of the disease, and people were very proud of the fact that they were quarantining each other and setting up roadblocks and sending their relatives back to the city or wherever they come from. And it became a kind of citizen movement, really, based, as I would argue in the book, on a kind of citizen science.
What were some of the major challenges faced by communities and responders during the Ebola epidemic, and how were they overcome? And do you think these experiences will be useful in future outbreaks? Could you see some learnings when COVID-19 hit, or do you think there are future outbreaks? When future outbreaks hit, there will be some useful learnings from these experiences that we can build on for the future?
Well, the big challenge was to get people to accept the bylaws, because even though it did allow, eventually the policy changed from about September, October. The British chief advisor on the Ebola outbreak, working for UK Aid, was Professor Chris Whitty, who's since become famous in Britain as the face of COVID-19 on the television. And he very quickly realized he needed some anthropological connection to communities. So he commissioned a small informal advisory group that met, I think, 3 times in London. And then he absorbed the message that something needed to be done about bridging this gap of understanding between the international community that wanted to kind of close down culture and stop burials and funerals and so forth, and then consign any suspected case to an Ebola treatment center, which was often 150 miles from where the patient had acquired the disease, because there are only a few of these, and they were like castles. They were There were guards on the gate. The families couldn't visit. There was no means they could travel 150 miles in any case. So there was a complete breakdown between communities and the Ebola responders, and it led to violence in some cases. People attacked facilities, or they tried to stop ambulances collecting suspected Ebola patients, and so on and so forth. So that was a major challenge, because it meant that cases were not being detected because people wouldn't come forward for testing, and rapid testing is the key to dealing with Ebola. Out of 100 cases showing symptoms, 99 of them will be diseases like malaria and typhoid. Only one will be an Ebola case, but that one case can then be spread throughout the entire community. So it's really important to get these cases tested. And what Professor Whitty recognized was that there needed to be some kind of intermediate facility which was close to the people, which they could understand, which they took part in, and would allow for the rapid extraction and testing of potential patients. So from November 2014, he introduced these community care centres. They were enormously controversial. The international community people, the agencies, the NGOs and so on, the international NGOs, they didn't want to have it. Some of them didn't want to have anything to do with this policy because they thought it was just a recipe to spread the disease. There was a huge amount of panic in the international community. But the CCCs were like field hospitals. They were built out of sticks and canvas, and they had fences around them, but they were not like prisons. And they were very open to families being involved. So families could come and prepare food for the patients, and they could even talk to them through the open fence and the open-sided ward where people were waiting while they were being tested. The CCCs actually increased the rate at which people were tested and then eventually isolated in a special facility if they had Ebola. And this had a very definite impact on the spread of the disease. So I would say getting the family back into healthcare, that was the biggest challenge of all. And in the case of Ebola, it was overcome through introducing these intermediate, family-friendly, localized Ebola testing places, because they treated all diseases. Whatever you turned up with, they would treat it. And so a lot of people were then discharged because they'd been cured of malaria or typhoid or whatever. And then they went away and they said to their families, oh, this place is great, you know. And so I think that was the biggest challenge that was overcome. And it was overcome really by a kind of nice compromise between what locally people had expected in terms of how you care for a sick person and what was necessary in the case of Ebola. So people were very flexible. They learned that Ebola really was dangerous. And if you played around with it, and if you tried to break the rules, a lot of you ended up dead. So that message kind of communicated very quickly. But they needed something that would allow them to become involved in the care of their sick patients, or at least, shall we say, the monitoring of their sick patients. And this adaptation, which was based on having a facility, this little committee, to connect between what people were saying in the field and what the international advisors were saying in places like WHO in Geneva, that disconnect was the problem with Ebola, and we overcame it with this little institutional innovation. It did have implications for further healthcare in the pandemic of COVID-19, because at first, in fact, people overreacted in Sierra Leone. The government closed down markets, and there was a draconian attempt to sort of disrupt the virus before they realized that, in fact, it spreads differently. It spreads on the air. It's almost impossible to control it. Ebola you can control. If you're strict enough, you can control it. But with COVID-19, very difficult. But what people did recognize that was useful from Ebola was that to be safe, you have to follow the rules. And the government is not just playing politics or messing you around by announcing that we need to follow the rules. So having that experience was very useful. And in fact, a lot of people will tell you in Sierra Leone, they told us in fieldwork often, that the reason we didn't have a big problem with COVID-19 was because we now know how to follow the rules. And the chiefs told us what the government wants us to do, and we did it. And the rules often were very useful in getting people to come forward for vaccination, because a lot of nonsense was being disseminated by people on on social media and so on and so forth about the dangers of COVID vaccination and so on and so forth. And quite a lot of this was hitting the ground, even in villages in Sierra Leone, because everybody's got a phone and they've all got relatives living overseas who care for their welfare and send them messages saying, don't have a vaccination because we've heard that it's going to kill you and so forth. And then the government said, no, that's wrong. And the president stepped forward to be the first person to be vaccinated, and then told all the paramount chiefs to tell their people, no, this is not dangerous. You should come forward for vaccination. So when we asked people why they came, because what we've done, we collected data at various stages through this process. We were observing it through the spread of the pandemic. And at first, when people heard about vaccination, we asked them, would you go for vaccination? And many of them said, no way, I know it's going to kill me, I'm not going for vaccination. And then 6 months later, we found them in the queue waiting for vaccination. And then we asked them why. They said, well, I don't believe in the vaccination, but I do believe that if you follow the regulations, you will be safe. So the chief has told us we have to go and get vaccinated. That's the law. So we went. And yes, I'm going to take the vaccination because the chief has promised it won't do me any harm. And I'm following the regulations, because with Ebola, the regulations kept us safe. So now it's the regulations that are going to, the bylaws that are going to keep us safe in COVID-19. So it's a very interesting carryover for COVID-19. And indeed, the international assessment, ECOWAS, the regional political organization in West Africa, has done an assessment. The Sierra Leonean response was one of the best. And I think the real reason is that it was because there was this prior experience of the discipline that was necessary, the social discipline that was necessary to deal with an outbreak like COVID-19 or Ebola.
In your book, you mention a lot of ways that local communities were empowered and how they built resilience amongst themselves. How do you think this empowerment of local communities can be sustained beyond the immediate crisis to build long-term resilience against infectious diseases? And do you think this was achieved in any way post-Ebola and before COVID-19 or after COVID-19 from the experiences that they had?
That's a very good point. And yes, I think it's one of the major lessons that we found from Ebola, that you've got to find a way of empowering local agents to deal with an epidemic. And I think the negative lesson of countries like Britain, where very little attention was paid to even the existing structures of public health response through empowering those local officials, health officials, I think they would have had a much better response. But anyhow, we await we await the results of the national inquiry that's going on at the moment. But I strongly suspect it will say something like that we should have empowered local communities much more and relied on local government and local public health officials. But in Sierra Leone, there was no mistake a second time. The empowerment had already taken place. The paramount chiefs have a mandate to report on health challenges, health threats. That's part of their function for national security. National security is being beefed up so that it deals not just with terrorist threats or invasion threats from across the border, but it's dealing with medical threats as well. So there's a much better system in place now as a result of the Ebola epidemic. The old problems are still there. I mean, there's a lot of underfunding. These things need to be properly funded because people have to be trained and they have to be paid and so on. But it has led to changes like the introduction of village health workers, who are kind of semi-volunteers, but they're paid a retainer. They're paid a little amount of money. It's not a living wage. They've got to be working on something else in the village. But the whole idea is that these village health workers live in the village and they're not going to leave it on leave or at weekends or because they're being transferred to somewhere else. And the more that there's that kind of decentralization of health care and health provision and reporting of diseases and so on, then the safer the country will be from these kind of pandemic threats that often come not from the center, they come from the margins. I mean, that was one of the big lessons about Ebola and is to an extent a lesson about COVID-19, though a lot of COVID-19 came through international air travel into the country, I'm sure. But it's when it gets a hold in remote rural districts and there's no capacity to respond, then you know that you're in trouble. Now, that lesson, I think, has been learned. So for all the failings of, there's much room for improvement and there's much more that can be done. But Sierra Leone has got, unlike Britain, Sierra Leone has got the basis of a response system that was actually functional and can be shown to have worked in COVID-19. And I think that's one of the big lessons. The more top-down you are, you look at the worst countries in the world for COVID-19, it's the United States, it's Russia, probably Russia's the worst, and countries like Britain. And these are very top-down societies. The command comes from on high. The only thing that matters is what the president thinks, and then everything has to be rolled out downwards. But in the Sierra Leonean case, you've now got some capacity for problems to be dealt with in situ. It needs properly resourcing, and people have to be better and better trained. And there's been some backsliding on village health workers and their payment, and it depends on international donations, and the resources in the country are not there to support it. But we now know what makes for a successful pandemic response in a country like Sierra Leone. It's local empowerment. And that message, I think, is beginning to get into some of the very top-down international bureaucracies. I mean, WHO is a very top-down kind of organization. And the decisions are made by the top experts in Geneva and so on and so forth, and then rolled out to the national representative and then rolled out further. And in the case of Ebola, that was nearly disastrous because there was very long decision-making time. Messages didn't get sent up the system, they only came down the system, and it took a hell of a long time before there was a proper international response in place. And the answer to that problem is to have a properly functioning local response system in place before the problem arises. So I think that's a global lesson. I think every country has got to learn that lesson.
One of the things you mentioned in your book, which I found quite interesting, was that you mentioned that a better functioning health system might have actually made the Ebola epidemic worse. I was wondering if you could elaborate on this, and how do you think that we could plan health system strengthening in countries like Sierra Leone alongside pandemic preparedness?
Well, the answer is the two things have to go together. The only reason I said that, I mean, there was a caveat to that remark. It was intended to provoke thought, and the caveat is that a better function, a well-functioning health system without knowledge of how to deal with an outbreak with an infectious agent like Ebola virus, if you don't have that knowledge and you've got a well-functioning health system, the health system causes more trouble through what's called nosocomial infection. So that's infection that you get by going to a health facility and being treated and then being cross-infected with the disease. So the two things have to go hand in hand. You have to have a well-functioning health system that will be beneficial so long as it's properly safe. And to make it safe, it has to understand infection risks. And that means that you have to introduce infection procedures that are much more rigorous than people have been used to applying in health facilities in the past. I talked to my Dutch dentist at some stage. I gave him a copy of my book, and he said, "Oh, that's very interesting." He said, because we dentists, because he practices from the local hospital, he said, we dentists have been asked to greatly toughen up on our hygiene in dental operations. And you can see that it's actually coming from the problem of Ebola and other infectious diseases. I mean, they're particularly worried about antibiotic-resistant bugs in hospitals and so forth. So even in the best funded health systems in the world, you're finding that there's now a new emphasis on hygiene and infection prevention. You have to introduce much more rigorous and strictly applied procedures. And you can still observationally see that many medical professionals forget. They're not well, you know, their own discipline breaks down because medical emergencies, people are rushing around and they're not necessarily thinking about how they're protecting themselves or the patient. So there's some huge lessons to be learned from following something like Ebola. It's not just an exotic disease, but it's almost a kind of living experiment in what goes wrong when you get cross-infection through the process of medical treatment. And I think we're now much more aware of the threat of nosocomial infection. And worldwide, I think medical systems are toughening up. Whether they've toughened up enough, I guess we could argue, but I think the lesson is out there that people require to be much more rigorous in thinking about infection pathways.
Thank you very much. Another thing you mentioned in your book is the links with your earlier work on Indigenous Agricultural Revolution and how you wanted to call this book originally People Science. I wondered if you could speak a little bit about the similarities in the arguments, and do you think the world has progressed and is more ready to embrace these ideas now than when you first started working on them?
Well, I realized when I rolled out this title for the book that in fact the argument has changed. So originally, when I wanted to call my first book on indigenous, it was called Indigenous Agricultural Revolution, but that title was imposed upon me by my publisher because I wanted to call it People Science, Agricultural Innovation in West Africa or something like that. And he said, no, Paul, you can't do that because the book will never sell any copies at all because booksellers won't know where to put it on their shelves. Do they put it in the science section? Do they put it in the wherever? Development books and so on and so forth. So I bowed to his superior knowledge of how to flog books. And indeed, he was right. I mean, the book did sell quite well. I still hankered after the title because the point I wanted to make was that many of the things that agricultural research claims to be, when we claim innovations on behalf of agricultural research, scientific innovations that are improving farming and so forth, quite often it turns out that there's a local equivalent, and that many innovations, so-called, farmers have been there first. And that's because I realized that was because there's many millions of farmers and they're carrying out natural experiments all the time, and they're accumulating the experiments that work. It's a kind of evolutionary process that the rubbish ideas get buried and the ideas that work spread. And people never, if something works, you never pay attention to where it came from. You just say, oh, this is what I do, this is what works. And my eyes were opened when I read some old files at Njala from the old colonial research station from the 1930s, where they'd been introducing nitrogen-fixing cover crops. And one of the species was I think it's a Mexican herbivorous, herbal herb, broad-leafed cover crop called Calopogonium muconoides. And they carried out tests of this at Njala to see whether they could use it as a nitrogen-fixing field crop to improve fertility in the soil. And it had escaped, and it has spread everywhere. So later on, when I was doing my field work in a village in Sierra Leone in the 1980s, I talked to farmers about fertilizer. I even bought them a bag of fertilizer so they could each have a cup, a butter cup, as they called it, because the local margarine was sold in these kind of small baked bean tins. And I gave them each a a tin and said, scatter it on a patch of soil and see whether that patch, the crops grow better, as a little trial. And I came back afterwards to see how it had gone. And one man told me, he said, "Oh, your fertilizer, it's not as good as my own fertilizer." He said, "I've got my own Mende fertilizer. This is the traditional one that our ancestors have told us is fertilizing the soil." He said, and I said, "Show me." And he showed me Calopogonium muconoides. And I knew that was introduced into Sierra Leone in 1932, but it has spread everywhere. And the reason was he was saying this is ancestral knowledge is because it worked. And he knew it worked, and he's right. And that's why he'd adopted the practice, not paying any attention to where he borrowed it from, but it just became part of his working practice. So I realized that there's a lot of interesting knowledge there out in the field that farmers have, that they've selected from practices that work and practices that don't work, and that we should be paying more attention to that, because otherwise you end up trying to teach them to do something they know how to do already. And you're wasting your time, and you're also getting into this problem that this man introduced me to, that I came with something I thought was an innovation, and he said, "No, I've got a better one." And he was right. So that was the reason I wanted to call that book Indigenous Agricultural, why I wanted to call it People Science, Agricultural Innovation in West Africa. But with the Ebola book, I realized it's a rather different argument, because here you have a sudden crisis which has never been seen before, because Ebola virus comes from, so far as we know, it comes from Africa, but it doesn't come from upper West Africa. There'd been no recorded outbreaks of Ebola prior to 2013. That was the first time it had appeared in the upper West African region. So it was an entirely unprecedented situation. So everything that everybody knows about how to deal with Ebola comes from their immediate experimentation in 2013, 14, 15. And I thought, well, that's actually a form of knowledge creation working in front of us, in our right where we're seeing people. It's instant, because they've had to find a solution to the problem. So it's rather different than saying, oh, it's something I got from my mother-in-law or got from someone who told me, even if it did come from an experiment by the British in 1932, but it had been there for quite a long time, whereas this is new stuff. And you couldn't say, oh, this is, I've learned this from my ancestors. And I thought, well, that's a form of people science as well. So we need to be clear that there's discovery science as well as knowledge that works, and the conditions under which people discover things, I think, are very interesting, and that's what I try and talk about in the book, because it's quite clear that the effectiveness of the local response was there before there was a major international intervention. So this local knowledge actually works, and people know it to work, and they discovered it for themselves, and that needs to be protected. It needs to be advertised. It needs to be worked with. International agencies need to have that category in their mind, people science, and they should be saying, when it's an unprecedented situation like a pandemic, how's that going to happen? How are people going to respond to that in Africa? And the beginning of the COVID-19 epidemic, there were some really ridiculous statements made internationally about how Africa would really suffer because Africans are so ignorant and they're not going to know how to deal with this, and so on and so forth. Whereas the evidence globally is that the countries that were most advanced in their own eyes in terms of science and technology, Russia, Britain, United States, these are the countries that have done extremely badly in terms of handling the pandemic, whereas countries that had very little going for them in terms of education and scientific resources and so on have managed much better. And the answer is because in the absence of other interventions, people had to rely on their own wits and their own knowledge and their own common sense, and they mobilized themselves to deal with these problems. And we need to recognize that and to support it, and to make sure that we make use of it instead of riding roughshod over it. The danger with the Ebola response was that the international responders were saying, we know everything about Ebola and you people know nothing. So they didn't even sit down to listen to what they were saying about the disease. Initially, there was a kind of complete, well, it came as a steamroller, as a bulldozer. It rolled over everything and said, we know, we've been told by some international agency, this is how you deal with Ebola, so now we're going to force you guys to do this. And then people kicked back and they said, no, this is nonsense. It doesn't fit with what we know. We know stuff, but unless you're prepared to listen to us, we're not going to cooperate with you. So I think that's that's one of the lessons that the international community and science in general has to learn. There's an arrogance about international development response, and there's an arrogance about international science that says, because we've got the highest qualifications and we've got the best laboratories and so on, we must therefore know everything. So my book is a little attempt to say, no, in some circumstances you don't know everything, and it makes much better sense to be cooperative rather than simply ride roughshod over what people know already.
Looking forward, what implications does the people science model have for future collaborations between the scientific community and local populations during health crises? What do you think are the key ways that we can bring these groups together to improve preparedness and response for future outbreaks?
Well, fortunately, there's been a development. I mean, I hate to put it this way, but because it falls into the trap of saying, okay, the good things always come from outside. But the only way you can get people to listen to what you're trying to say, if you're a villager in somewhere like Sierra Leone, you know something important about soils, you know something important about how to deal with Ebola and so on. But the only way you're going to get taken seriously is if somehow you can kind of push that message upwards and it fits into some category that people have already got. Because if they don't have the category in their head, they just don't hear the message. There's a lot of racism, there's a lot of arrogance. It's not just racism, but it's a sort of intellectual arrogance that people have because they're better trained or they're wealthier and so on. They think they know the answers to everything. And one of the ways that you can overcome that is by kind of hitching a ride on some of the developments that are going on internationally. So I've been very interested in the rise of so-called citizen science. And it annoys me enormously because citizen science presents itself as if it invented itself about 1983 and it's now going great guns and it's spreading all over the world and so on, paying no attention to all the literature that preceded this. That goes, there's even 19th century literature on forms of citizen science, plebeian science it was called, in Victorian Britain, where people became fed up with the professional middle class doctors and the knowledge that they had, because often it was highly dangerous, and you paid a lot of money and you didn't get well. So there were various grassroots movements that wanted to bring their own understanding into the picture and to make it scientific, to make it evidence-based and so on and so forth. So this is no new thing. So it's very annoying to me to hear people talk about citizen science as if it was something that was invented in the 1980s. And first it grew out of amateur astronomy, and now it's bird lovers and so on are involved and so on and so forth. But nevertheless, it's a category with which you can work, because you can fit your own, if you want to support village people science, in my sense, in West Africa, you can make it resonate with people that provide money for these things by calling it citizen science. So I think there's some kind of merging going on. It's we need perhaps some international conferences to bring the different parties together and to get a better understanding that this is the heritage of all societies. It's certainly not only in Africa that you get it everywhere. And that there are different traditions. I know people who've been working in India for years on these issues, and they would also like to say, you know, look, you've ignored everything we've done, and that should be part of the discussion as well. and there are peasant associations in Latin America that have been doing the same thing. There's nothing unique about the African experience in this regard. It's a kind of global movement, but there's no resources going into putting it together and sustaining it and pushing the messages upwards. So we need some kind of game changers in order to bring about a merger between these more top-down citizen science initiatives and these bottom-up plebeian peasant-driven interventions. And there's a lot of people that have worked on it over the years, and it's no new thing. And IDS is very familiar with these developments and has contributed in many significant ways. The work of Robert Chambers, for example, is a shining example. But we kind of need to bring it together so that there's a more joined up approach to supporting it. And so that the approach to supporting it goes down to the village levels. It goes down to these plebeian scientists or these peasant scientists. And they're not just working all on their own, trying to build knowledge, but they're able to document it. Ideally, that they should be able to publish some of their findings in international peer-reviewed journals. But getting peer reviewers that will be able to respond to citizen science of this kind, or plebeian science or peasant science, is the devil's own business, because we're also busy trying to further our own careers and build our own reputations and so on, that there's very little capacity in the system. So it probably needs some imaginative journal editors who are prepared to encourage these kinds of developments and provide outlets. And then we need resources going into moderating it, because it can't just be any old stuff. I might wake up one morning and think I know the answer to COVID-19, but in all probability, I don't have any evidence that that is the case. So we need to compile the evidence, and the evidence often has to mean linking together results and experiences across a very large community, because we're talking about a mass movement here, and how to get momentum into that mass movement and how to make it scientifically coherent and to make it experimentally robust. I think these are big challenges, but there are people working on it, and more support should be given to it. And the international world of science should take note, and it should try harder to be more accommodating to some of these tendencies.
I think that's probably as much as we've got time to talk to you about today, but thank you so much for taking the time to come and speak to us about your work and your career, and particularly your book. And you can really see how we need to keep these lessons that we've learned from previous epidemics and apply them and take that learning on forwards. And hearing all about the work that you've done with communities, it will be so useful for future outbreaks. So I do really appreciate you taking the time to come and share them with us for this podcast. Thank you.
You're welcome. It's been nice talking to you.
Thanks for listening. Please subscribe and share to help us spread the word. Do you have a feature that you'd like to appear in a future episode? Then get in touch on email at betweenthelines@ids.ac.uk.